So now we'll move to our case of stent thrombosis, and our Dr. Sulaimi from Kuwait help us in this, mashallah.
Good morning. Thank you for allowing me to present my case. So my case is a case of coronary marination. So if any of you cooks at home, you know that marination means we tenderize or add flavor to the food by putting a liquid mixture. So I'll explain what marination means in terms of doing it in the coronaries, okay? So just to say this up front, I didn't do actually this case, but we had like a nice discussion among colleagues regarding what happened and how to deal with it. So basically we have a young 29-year-old male, okay, who has a history of smoking, and of relevance, he has a history of axillary thrombosis back in 2019, and he was it was treated by the vascular surgeons with embolectomy. Okay, otherwise, successfully treated with embolectomy, and otherwise he has no known medical conditions. Okay, he doesn't have diabetes, hypertension, nothing. And he underwent thrombophilia screening, vasculitis workup. All of it was negative back in 2019. And he's been on warfarin, so he's been anticoagulated. And he presented obviously with chest pain, and STEMI was activated in the emergency department. So this was his ECG on presentation. Obviously, diffuse ST elevations, basically in the anteroseptal, anterolateral leads, all elevated. You know, the investigations that were done, obviously the ECG that we showed, and the labs, significant for elevated troponins. Hemoglobin was fine, platelets was 500. The renal function was normal. His INR was actually 2.6, so he was on therapeutic warfarin. And the echo done obviously after the primary PCI, which we will show, his EF was 40%, and he had hypokinesia in the LAD territory. So primary PCI was done. Okay, this is the non-culprit vessel, which is the RCA, and you can see like a normal caliber vessel, no disease. And then the left side, clearly there is a thrombus in the proximal LAD, and the circ looks okay. So aspiration thrombectomy was performed, and flow was restored. However, the very distal apical segment of the LAD was still occluded by the thrombus, probably propagating distally, but there was restoration of flow. And then the operator decided to put a long stent in that segment that had the thrombus. So the stent was deployed, and I'll show you the final result. But this was the what was extracted with the export catheter, like a very large thrombus. And this is the final result. Overall looks okay. I mean, obviously the distal LAD is still occluded. So patient basically was transferred to the CCU, and he was observed for the next 24 hours. This is just to review the case. You know, as I said, like aspiration thrombectomy was done, and the flow was restored, and then the proximal LAD was stented successfully. And he was given actually a bolus of IV antithrombotics. He was given tirofiban and planned for 12 hours post-PCI. And then he was transferred to the CCU for close monitoring. 24 hours later, he had chest pain, and ECG was done, and it shows again the ST elevations, anteroseptal, anterolateral. And we brought him immediately for an angiogram, and we see that the stent got thrombosed again, or the vessel got thrombosed again. And now it became very complicated. So what was done, aspiration again was done, and flow was sort of restored. And then we did imaging. So we did OCT, and our OCT is the Terumo OCT, so that's why you don't see color. But the OCT showed diffused thrombus burden all over. And you can actually see normal caliber vessel. There's no disease in this vessel, no atherosclerosis. So it's a totally normal vessel, but it's all thrombus, heavy burden thrombus. So this is what the OCT confirmed to us. And then we did what we call the Marinade Technique, and I'll explain it. Basically, the Marinade Technique, what we do is we wedge a guide extension catheter, which is what you see here, and you obviously have a balloon distally to occlude the vessel, and you give 1/10 of a dose of TNK, tenecteplase, and you keep it inside the vessel to marinate, basically, for around 5 to 10 minutes. And, supposedly this has some effect. So you keep it there for 5-10 minutes, and then you deflate the balloon and see what you have. And essentially, I mean, still there's a lot of thrombus, but at least there's some flow now distally. So, I mean, the operators who did this case spent around 2 hours trying to restore flow, and they ended up using the Marinade technique. So again, as I said, this is just the summary of the case. He had acute stent thrombosis. He was given antithrombotics, heparin. He also got a balloon pump placed because he was hemodynamically unstable when he got the stent thrombosis. And we tried to do aspiration again, OCT. They gave like IC vasodilators to try to improve the flow. And then we did this Marinade technique, which I explained. And then at that point, we ran out of ideas, so we just sent him back to the CCU, kept him on antithrombotics, heparin, all of that stuff, and hope for the best. So the next day, patient was chest pain free, but we decided to take a look again. Unfortunately, like the distal LAD is totally occluded, and now it's infarcted. The good news is, though, that the patient recovered and did well. So he eventually recovered. He had extensive LAD infarct. He was placed on triple therapy initially for 1 week, so aspirin, Plavix, and warfarin. And then we kept him on Plavix and warfarin, planned for a total of 12 months. At the time, we also consulted rheumatology, hematology, and vascular, and they all gave their input, and basically all the workup returned negative again. So we don't know exactly what's the mechanism behind his thrombosis. It's like in situ thrombosis in the vessels. So patient is basically being followed in the outpatient. He's doing well, and he's being followed. So what are the learning points in this case? So I think, first of all, whenever you have a young patient presenting with STEMI, there should be a high index of suspicion that this is non-atherosclerotic. So not all thrombus-related occlusion should be stented. And consider not to implant stents, first of all, when you have a high thrombotic burden, when you have poor flow, and without evidence of significant stenosis. Maybe it's best treated with a different strategy of giving IV antithrombotics and a delayed PCI strategy. And I think it's also important, whenever you're in doubt, that you should do intracoronary imaging, whether it's IVUS or OCT, to define the pathology and treat accordingly. And possibly also manual thrombectomy has its limits, and maybe consider having mechanical thrombectomy catheters in the lab, such as the Angiojet or the Penumbra, and maybe they have utility in these kind of cases, and they should be essential tools in the cath lab. And finally, the Marinade technique can be used as a final resort to reduce the thrombotic burden. And that's all. Thank you very much. Any questions?
Thank you very much. Excellent comments, Abdul-Majid.
Thanks, Ali. I think you summarized it in the message. Such cases, we usually defer, or we try to defer, as you say, the highly thrombotic lesion, young patients, don't know what's the chance that there is a ruptured plaque there without an imaging, but this is a a typical case that I would I would defer when they come this time, especially if I don't if I don't see a heavy atherosclerotic plaque that if once you restore the flow, I think it's the time to stop. The anticoagulation after you after the stenting, so there was a GP2/3 inhibitor.
Correct.
Was there an intravenous heparin? Or?
Yes, both. Yeah, both.
So, I mean, any questions? Yeah, Musa, تفضل.
Thanks, Ali, for Dr. Ali, thank you very much. It's a really good case, and I reviewed this case when you submitted to us. One thing, we are seeing nowadays during the COVID also, people presented with ST elevation, a heavy thrombus, and they have absolutely normal coronaries. And most of them ended up not to stent them. We will have another talk on heavy burden thrombus next session, and Dr. Ahmed Qasim has a very nice case, and we'll spend time. But I think, as you said, the learning point is that the fact that imaging also will help if you don't find, especially young, 29 years old, and the artery is normal caliber. There's no atherosclerotic plaque in the RCA and the circ. The other things, with all respect, Anna, I will, الأجرستاد or tirofiban 12 hours, a little bit short in heavy burden thrombus. You can give up to 24, even I give 48 hours, some cases 72 if there is a heavy burden thrombus. It's a very tough to decide whether deferred strategy or give thrombolytics and then you do stenting later on if there is atherosclerotic. This is debatable, but I think depending on the scenario here presented in ST segment elevation, so maybe he will have a lot of complications. So deferring strategy is not really in a thing that you will do it. The other things, the lytic is very good, but in the literature they give half of the huge, or one third of the, in the literature there's recommended to give 1/3. So there's difference between 1/3 and 1/10, Ali, to give according to the literature. You didn't think to give 1/3?
There's no like defined way of doing the Marinade technique, as far as I know. My colleague, he read about it, and I think there's someone called Dr. Aaron Grantham who came up with the technique, and he gave 1/10 of the dose for the marination. That's my understanding, but I don't think there's a defined way of doing it, as far as I know.
Just short comments. What I know from literature about marination, to give intracoronary heparin and 2B3 inhibitors in burden thrombus high, and differ the process after 2 or 3 days. Another point about the technique of Marinade technique, I don't agree with inflation of distal balloon, because when we give the selective intracoronary thrombolytic therapy, we need to dissolve the thrombus, and the major issue is the distal embolization of this thrombus and obstruction of microvasculature. So we need to mix all this intracoronary thrombolysis to all the burden of thrombus, even in the distal part.
Dr. Ahmed, did you 1/3 or 1/10 of the dose?
Yeah, there is many literature, but the most important one from the Acute Cardiac Care Journal of Europe in 2014, I think, give 1/3 of systemic dose.
1/3. تفضل دكتور, please.
Assalamu alaikum. Nice case, Dr. Ali.
Thank you.
Would like to add the point that it's really uncommon nowadays to have a young patient with such a thing. From actually what we have, like 3 times a young patient who presented with similar condition because they take steroid as a bodybuilder, hormones, steroids, and something they called it X factor, lipid burner, something like that. So, and what actually we have to focus on those things in a patient who is young, that it could be a cause. The second thing is, I think in such cases it's better to treat conservatively. I mean, as you mentioned, Dr. Musa, glycoprotein to B3 should be longer. And I had experience with one patient, his age was 25, bodybuilder, presented with this similar condition, LAD, had a thrombosis. So glycoprotein 2B3 inhibitor, then we discharged the patient for 1 week on a triple therapy. I mean, DUAC and double antiplatelet therapy. So we bring him back, we keep observe him during even the time of discharge. We repeat the coronary angio before discharge, then we repeat it after 1 week, then after 1 month. And you know what, 45 days after triple therapy, LAD was almost normalized.
Correct.
Thank you.
Dr. Abdallah.
Thank you, Dr. Ali, for an excellent case presentation. This is a very difficult case to deal with. I mean, high thrombus burden is a common problem that we face. It's difficult to deal with. But I think the interesting thing about this case, we still don't know why the patient has a thrombus in the LAD. And I think I had a couple of cases in my practice. When I find this, I look for a PFO as a cause for paradoxical embolization. Which is very important because you need to close it, otherwise the patient will have another event in the future. The other thing will be LV thrombus, and someone who is known to be very prothrombotic. Thank you.
Yeah, good point. Good.
Thank you. Good morning, everyone. Intervention cardiologist. I have a specific comment regarding the Marinade technique. I think the Marinade technique could be considered, but not when you're dealing with a proximal lesion, especially in a lady. And one of the things I've seen is actually a spillover of the clots into the LCX. Because what do you do when you're trying to block the flow? You're trying basically to maximize the fibrinolytic therapy to the clot. But what could happen actually, you have a spillover backwards, and this is one thing they have to keep in mind, and you should not consider if you're dealing with a proximal LAD. Second, I think we use a standardized dose for all patients. And this patient has a very large coronary artery. And I think in this situation, I would not be going with 10%, I would be going at least with third, and maybe even a 50% of the dose, because it is a large clot, and if you had a mechanical thrombectomy system, this is the kind of patient where you actually want to do a mechanical thrombectomy system. Thank you.
Yeah, good point, thank you.
Hatem, tfadal.
Assalamu alaikum. Good morning. Hatem Alawati from Oman. Just a small comment on the dose of intracoronary lytic. There is, as you can see, a lot of disparity in the described reports. Do you give 1/10 the dose? Do you give 1/3 the dose? And I think you need to take into consideration the bleeding risk. This was a young patient with a low bleeding risk, but you can face the same situation in a 70, 65-year-old who has CKD, who has AFib, who's going to require to be on lifelong anticoagulants. The recommendation for intracoronary lytic is up to a third of the systemic dose, but what you can do is you can give aliquots, say for example 5 milligrams or 10 milligrams at a time if you're using TPA, for example. And then if you restore flow, then that's probably all you need to give, because your patient is going to go back to the ward on glycoprotein 2B3 inhibitors for at least 24, maybe longer hours. He will need to be on anticoagulation plus dual antiplatelets.
Thank you.
Thank you very much for the case. This is the case what everybody calls it the nightmare in the cath lab.
Yeah.
Absolute nightmare. Large thrombus, proximal LAD, young chap, what to do with them. I mean, the last thing in the world is to place a stent. No doubt, we all agree on this one. I think the evidence behind the marinated technique and every local antithrombotic treatment is quite weak. I don't think there's any strong randomized data behind this. And I think from the acuity trial, Professor Greg Stone, when they did the trial, as you remember, they injected locally in every thrombus. And there's no evidence that there's any value from giving it systemically.
Yeah.
So I think, there's argument about this, but once you are in that position, everybody will try every resort at the end of the day. But as probably Dr. Akbar said, it's something that I would give them prolonged GP2B3A, just as much as anticoagulation and mechanical thrombectomy. I think that's the key in those cases. Don't put any metal in this angry thrombotic area. This is the learning point for all of us, I think.
I agree. I agree totally.
Thank you.
Ali, I think one thing to point out that this is probably a hypercoagulable is the axillary thrombosis. Upper DVT always trigger us that there is a thrombophilia time. It's not like a DVT. So that probably in his history might think that this is a young with upper DVT or upper axillary, to point out to re-investigate, which is a good thing. You re-investigate again the thrombophilia factor to see if he's hypercoagulable. Thank you.
Yeah, thank you.
I'm sure you agree with me, this case was enriched with the amount of information we get from everyone here. So now I think it's time to move. Musa Akbar, you're leading this next session. Thank you.
Now we'll go to heavy burden thrombus. We'll just give more time discussion on that. So we have a live meeting with Dr. Habib Gamra. He's a cardiologist in University Hospital in Tunisia, who will give us a talk about the heavy burden thrombus, the tips and tricks. Dr. Habib Gamra would like to welcome you in the guest complication show, and we have honor to have you with us, and we'll leave the floors for you to give your talk.
Thank you very much. I'm honored to be with you today, and I would like to thank the board of the Gulf Intervention Society for inviting me to a very interesting meeting. I was hoping to be with you physically, but unfortunately that was not possible, and I hope this would be possible next time. I would like also to thank them for giving me the chance of talking about a topic that I personally consider a very important one, because it's a routine challenge in our cath lab. Just to let you know and remind you that actually having a high thrombus burden is not benign. And in the Tuton trial, they have compared in another paper than the original one that was published in 2015, they have compared the outcome of patients with high versus low thrombus burden, and you can see that having a high thrombus burden was associated to very adverse outcome in terms of stroke, heart failure, cardiogenic shock, and overall on cardiovascular death, as you can see in this in this figure. Now, just also to remind you that there is a classification of thrombus burden, and it is a high thrombus burden when we get to grade 3 or 4, meaning that we have a thrombus that occupies more than half and less than 2 vessel diameters for grade 3, and more than that for grade 4 and 5 when we have a complete thrombotic occlusion. Now, there are factors favoring large thrombus burden, factors that are related to the patient, such as smoking, male sex, to the lesion itself, particularly patients with acute coronary syndrome, and especially STEMI, to the vessel and right coronary artery and saphenous vein graft, and aneurysmal coronary arteries are more prone actually to have such thrombus burden. Factors related to the disease, to the environment, and in STEMI patients, particularly the ones who present late, more than 12 hours, or those who present with cardiogenic shock, and factors related to PCI, and I like this term, angry clot phenomenon, that is triggered by a guide wire balloon or stent. Now, I just would like to illustrate the issue and some tips and tricks through 2 cases. The first one is a 42-year-old male who presented with a STEMI with posterior extension, who got thrombolysis, and when he arrived to the CCU, he didn't have any more chest pain, and the EKG is this one. So you have Q-wave D3 and in leads 3 and AVF, but no more ST elevation. Despite that, the cardiologist on call decided to take the patient to the cath lab. This is the left, and but you can see that the vessel is open with a very high thrombus burden, clot that is there just after a tight lesion. you can appreciate that thrombus in this view too. And of course, there was few questions how to deal with this. The patient has STEMI, he has no more chest pain, he resolved ST elevation. What would you do? The colleague on call, he decided to do what he thought was the right thing. But you know what we can ask ourselves, we could aspirate that time and then stent, or maybe treat that lesion with a small balloon just to destroy a little bit the thrombus and then stent, give QB3 inhibitors and then stent, or to take the decision of doing nothing and just defer the procedure for later on and giving the chance for the thrombus to decrease in size or maybe to go away. Now, thrombectomy was clearly an option, and you know, after TAPAS in 2008, TASTE in 2008, and TOTAL in 2015, there's a clear recommendation from the guidelines to not use routinely thrombus aspiration. This is the European guidelines. In the American guidelines, they leave a niche for that, and they mention that selective and bailout aspiration thrombectomy during primary PCI have a 2B recommendations. The other possibility is also to defer the procedure, and there are of course advantages of doing that, because actually you will give the chance to thrombus to go go smaller and perhaps less risk of no reflow or slow flow. But there are disadvantages with deferring stenting, because there is a risk of reocclusion. Of course, it will increase the hospitalization time and you will increase medical expenses. But if you do it right away, there is certainly a risk of slow flow or no reflow. Several trials on deferring strategy versus doing it right away, different time delay in terms of referral or deferring. But just to show you, there is a meta-analysis that was published in 2017, and perhaps it does summarize this issue. And the conclusion of that meta-analysis is that compared with immediate stenting, a deferred stent strategy did not no reflow, function, or repeat revascularization compared with immediate stenting in patients with ST segment elevation MI, but showed an improved left ventricular function in the long term. So what happened to this patient? Our colleague decided to go ahead and do it right away, not defer the procedure, use an export aspiration catheter. You can see it here. After the aspiration, things have improved. Thrombus has decreased in size, and this allowed a stenting of the lesion with an excellent result end-to-end. The second case is a different story. 72-year-old male, diabetic, hypertensive, anterior STEMI with cardiogenic shock, who presented 3 hours only after chest pain onset. The right coronary artery system, you can appreciate it here, normal. And this is the left coronary artery system with a large thrombus in the proximal LAD with a tight lesion. There is a slow flow in the left circumflex. So the youngest of our team, a junior cardiologist, was doing this in the middle of the night. So he decided to go ahead with thrombus aspiration. But what he did not notice is that there is also a thrombus in the left circumflex. The patient was very unstable on cardiogenic shock. This is the export thrombus aspiration catheter. Improved after aspiration But you can see here is a thrombus in the left circumflex too, that it was initially there, and it has actually worsened after the thrombus aspiration procedure. Stenting of the LAD, but you see that there is a thrombus here. The cardiologist, he did wide circumflex. I don't have that sequence here, but unfortunately, despite this good result, satisfactory result, I would say, on the LAD, the patient died on the table. And of course, we had to sit down the following day in order to try to draw a few lessons from there. Was there any need to go with GP, with the 2B3A inhibitors? And maybe as soon as the procedure has started, was the young cardiologist expert in using the aspiration catheter? Probably not, because this has worsened actually after the thrombus aspiration, and that might explain actually why we have negative thrombectomy trials after the TRAPAS trial, because actually expertise was just required in those trials. Manual aspiration was used all the time, and you know that we have a problem with manual aspiration as opposed to mechanical aspirations. Catheters are not the same, so there are issues, and expertise is one of the requirements in order to have a successful thrombectomy procedure. Now we have new catheters, the Penumbra aspiration catheter is a very promising one. Data were published, were presented actually. They're not published yet. The Cheetah trial, 400 patients, is awaiting publication, but the results were presented at TCT 2021, and the results are really encouraging. And again, this is not a manual aspiration catheter. This is a continuous mechanical aspiration system. How about the other options? Of course, pharmacology, and particularly 2B3A inhibitors. We have small trials that have showed actually very important effect. This is a small trial showing the benefit of using IV abciximab as a rescue maneuver to dissolve the thrombus. But small trial, but the results are very encouraging. Now, the guidelines, again, this is the European ones that find a place, a niche for using 2B3A inhibitors as a bailout procedure. Intracoronary thrombolysis, I have listened to the colleagues talking about this issue in the previous session, and there are small trials using fibrinolysis, tenecteplase, or others. 1/3 of the systemic dose is used, and this trial that was published in 2014, very encouraging, with an effect particularly on the grade of the thrombus that goes down after IC thrombolysis. This is another trial. It's a Chinese trial that was published in December in 2019. I find a little bit bizarre the drug used. It was pro-urokinase drug, and they have compared actually thrombus aspiration versus intracoronary thrombolysis. The conclusion is intracoronary thrombolysis was superior in terms of improving myocardial microcirculation perfusion. So there is no solid data, but in case of a huge problem, you have to use what you have in hands, and one of those is intracoronary thrombolysis, preferably with tenecteplase. I have to mention that there's another trial that have shown that actually there is the risk of increased myocardial hemorrhage using intracoronary thrombolysis with tenecteplase. At the end, I just would like to suggest to you this algorithm for the management of large thrombus burden during primary PCI. So this would depend mainly on the magnitude of the thrombus. If it's a grade 0 to 2, then you go ahead and do it with the direct stenting and the minimal inflation, just a single inflation, and you go. If the thrombus is of grade 3 to 5, then it depends whether you have an antegrade flow or not. If you have an antegrade flow achieved and no ongoing ischemia, it's better to defer the procedure. to defer stenting for 24 to 48 hours. However, if you have no flow, then thrombus aspiration, preferably with mechanical thrombectomy if you have it available, and then you go ahead with the direct stenting. So in conclusion, dear friends and colleagues, large thrombus burden, particularly in acute coronary syndrome, can further complicate PCI due to distal embolization, no slow reflow, or embolization into a non-culprit vessel. There is no ideal management strategy. Each patient requires individualized approach depending upon operator experience and expertise. There might be a benefit from IV or IC administration of TBA3A inhibitors. Direct stenting is recommended if the extent of thrombus is small and in the absence of tortuous and calcified lesion. However, if there is a large thrombus burden, manual aspiration thrombectomy may be considered, and in the presence of a very large thrombus burden with no integrated flow, mechanical aspiration, angiogram or penumbra, if you have it, may be useful. And if integrated flow is restored and large thrombus burden remains without ongoing ischemia, 2B3 inhibitors with heparin and deferred stenting for 24 to 48 hours might be considered. In summary, you need to have an individual approach for each patient and have a tailor-made treatment for every single patient. Thank you very much. And this is an invitation to have you with us in Morocco next October for the PAFSIC 2022 meeting that will be organized jointly with the National Congress of the Moroccan Society of Cardiology. Thank you very much for your attention.
Thank you very much, Dr. Habib Gamra. We really appreciate your talk and overview of the management of heavy burden thrombus. So I will ask the panelists if they have any comments or a question before I go to the delegates. Please, Ali, you want to ask? Please.
Thank you very much. Nice case and nice review of the literature. There's two things I want to touch upon. First of all, and you talked about this in your presentation, regarding the guideline recommendation on routine use of aspiration thrombectomy. You know, as you know, there's been a couple of trials. There was the TAPAS trial that showed there was benefit, and then there was a succession of other trials, like the Infuse AMI and Total, showed no benefit, and that's why it was downgraded. And as you said, like, I think it's operator or expertise dependent. You know, whenever you perform aspiration thrombectomy, is the operator doing it correctly or not? That's one thing. But you know, as operators, we notice that whenever you reduce the thrombus burden by aspirating the thrombus, you get better results. And it also begs the question of whether we should work on trials looking at the use of these mechanical thrombectomy catheters. I think there's a role for them, and especially in high thrombotic burden cases. And maybe we should, perform some kind of randomized trial, and I'm pretty sure we'll have positive results, in that aspect. The second thing I want to touch upon is the, whenever we have a primary PCI case, patients get loaded with antithrombotics. Either, the guidelines now recommend prasugrel or ticagrelor over use of Plavix. These patients, they come with a lot of pain. The emergency doctor, he gives a ton of analgesics like morphine and fentanyl. And what those medications do is that they slow the gut motility. So the drugs, they don't get absorbed. So probably there should be a way of avoiding these drugs. I mean, if the patient obviously has pain, we have to make them comfortable. So maybe use things that are alternative to these opioids, like IV paracetamol to control their pain so that the drug gets absorbed more quickly. And then there's obviously the role of IV cangrelor, the new agent. And I think it also has a role in these high thrombotic burden cases. Thank you.
Any other comments from that? Tfadal, Doctor.
Yeah. Thank you very much, Dr. Gamra. It's a great presentation as usual, and you summarize it all. But I think it's in the same line of an export catheter. We used to do it routinely. In every STEMI, it's a part of a practice, and you just put a export there and take a clot out. And the guideline told us that this is class 3. But people just, after that, feel that it's not useful, and I don't completely agree with that. I think it's routinely is not useful. Maybe it's a bit harmful, but in the big clot burden, still export catheter and mechanical extraction is very helpful. If you take chunk of clot like this, the flow is better and the no reflow phenomenon is less, and the case will be easier. Second thing, I think it's all what you mentioned can apply to acute thrombosis, either in a STEMI or stent thrombosis. But when it's come to a late presentation, like a patient present with a STEMI, received thrombolytic therapy and come to your cath lab and after 48 hours and he still have a big clot there, or a late presentation has received only medical therapy and in the cath lab you still have a big clot. I think it's all our medication here doesn't work very well. Again, mechanical or export catheter doesn't work very well. But the good thing that even direct stenting have a less complication. And personally, I face less no reflow phenomenon, less migration of clot, and my threshold of stenting, even if it's big clot burden, in a late presentation is very low. So we'll love to hear from your comment on that regard, and see from my colleagues.
Dr. Habib Gamra, would you comment of the late presentation when the patient comes to you with the late presentation of STEMI and there is still heavy thrombus? Would you go with direct stenting or you do something else?
Yeah, thank you very much for the question. Late presenters are a major problem, and actually the worst patients actually we're having with high thrombus burden are those who present late. What you usually do, direct stenting when you have a high thrombus burden is not the right thing to do, and thrombus aspiration unfortunately does not work very well because actually after I would say 4 to 6 hours, the thrombus would change its configuration when it becomes really solid and then more prone to be aspirated with the current, particularly manual aspiration catheters. So what you usually do is try to destroy a little bit the thrombus using a small balloon inflation, and try to have a flow. Once you have a flow, then probably you can go ahead and do it. But if you don't have a flow, I don't think it's really dangerous to go direct stenting. Now I have another comment regarding the negative trials of thrombus aspiration. What happened after TAPAS, TASTE and TOTAL, and this clear recommendation from the guidelines to not using thrombus aspiration routinely. You see that the trials that have been conceived later on are focused actually not to routine use, but rather to using it in high thrombus burden. And look at the inclusion criteria of the CHEETAH trial, for example, that has used the penumbra. They have included patients with high thrombus burden. So routine use, again, the routine use is not what is recommended to thrombus aspiration, but using it in high thrombus burden, I think that's the niche where actually we need maybe to have other trials to validate again this tool, this important tool. I think it's really wrong to don't have thrombus aspiration catheter in your cath lab after the USC and the American guidelines.
Yeah, further.
Just a small comment on a late presentation, big thrombus. Definitely, you need to see the distal segment to be able to stent. So if you don't see it, you have to balloon to be able to know what's your size of a stent. But I think one of the tricks I learned over time is take a longer stent and try to avoid both dilatation. So you go 1-to-1 kind of sizing with a stent, and try to go slowly till you have the shape of a dog bone shape, like you trap the clot in the middle of the stent, and the stent will be able to fragment the thrombus, and that way, most of the time, you will not have any problem of distal embolization.
We have a question from the participant, Dr. Hatem, تفضل, or comment.
Thank you, Mr. Chairman. Professor Gamra, thank you so much for the detailed overview. I think the common denominator in all the comments in terms of managing this hefty thrombus burden is to try and minimize distal embolization as much as possible. Could I perhaps hear from you a comment on whether you think, and the data is very scarce here, if there is any role for distal embolic protection, especially if you bring the patient on a subsequent session where the thrombus is more organized and perform thrombectomy, the risk of distal embolization is high. Or if you plan to direct stent in the index presentation where hefty thrombus burden can also embolize distally. Do you think there is any role for such devices?
Based on my personal experience, I don't have much experience with those devices. What I can tell you is that those devices have been used maybe 10 years ago, particularly in high thrombus burden in large vessels like Safine's vein grafts. There are data encouraging results, but I don't think now that is now currently used or routinely used in the setting of acute coronary syndrome, because this is the device. Another device that would probably actually worsen the thrombus and the thrombotic environment. So to give you a clear answer, I don't really have an experience with those, particularly in the setting of acute coronary syndrome. Theoretically, there is certainly a benefit, but in practice, I have no experience with those devices.
Dr. Habib, we have two questions from our delegates. Fadal, Doctor. One question will be addressed, Fadal, to you.
One is, thank you very much for the nice talk. It's just for one case we always overlook it, which is heparin-induced thrombocytopenia. We don't ask, sometimes it's life-saving, and it will redirect our treatment and management for the case, which is, we have to ask patient maybe if he has been exposed to heparin in the last week. It's very easy to ask if he has been exposed to heparin in the last week, for example, and then there are, or like he had any scan reaction or platelet reduced by more than 50%. It's very easy to ask them. It will take us 5 minutes, but it will redirect us to use, for example, direct thrombin inhibitors instead of giving other agents, and it will save us. In 30 years, I have seen so many cases with myself or my colleagues, and we lost patients sometimes. We couldn't overcome the thrombus coming again and again, next day, the third day, because the effect of this, the antibodies will last about 7 days, something like this. So I think it's worth thinking of head syndrome sometimes, especially in recurrent thrombosis, the next day, the day after, the day after. I have a case about 2 months ago where I work.
Any comment, Dr. Habib, on the head with the thrombosis, with induced thrombosis?
I have never came across a similar case. It must be very complicated to manage in the cath lab because you don't have much drugs to be used. But you know, I have never had a similar case. Or we have coronary occlusion with the thrombocytopenia induced by heparin. I don't know if you have any, and how you did manage that.
Okay. Thank you for your question. Please, Doctor. And then last question, and then we'll move to our next case presentation. Last question. Fadal.
Good morning, Dr. Habib. Thank you for such a great presentation. I think the case that you showed where you have an LCX clot present, I think this is the dreadful situation that we all fear in the cath lab. I think most of us been in a situation where you try to aspirate from the LAD and then you end up with a clot in the LCX. And when that happens, it's one-way ticket. Patient is not coming back. So my question to you in this situation where you actually have approximately a LAD clot, for example, what would be your recommendation? Because in those patients, I'm very cognizant of the fact that you may dislodge the clot into the LCX. And the LCX in this situation, that territory is the only saving territory for that patient. And if it goes down, patient goes stunned and at rest. What would be your recommendation? And also, would you crash those patients on an ECMO machine in that situation? Thank you.
Yeah, thank you very much for the question. I think one key point in that particular case is to be as fast as possible. So you have to act very quickly. When you see the thrombus, the left circumflex, it means that the patient is going in the very worst outcome, in a very bad direction. So you don't have to wait for initiating 2B3 inhibitors right away. And then while your left circumflex and thrombus aspirate also as fast as possible. So being fast is absolutely key. If you start thinking, then things will go very, very quickly and you will lose your patient, as it happened to this particular case.
ECMO, if a patient arrests on you?
Yeah, of course, ECMO, but it's too late. If you get to ECMO, then I think, I don't think that the patient will have a better outcome. If you get to ECMO, then you get to a very bad direction, and the outcome, will be,
Thank you.
Not be brilliant.
Dr. Hatem, you want to do a last comment before we move?
Sorry, just to follow up on the very important observation or comment you made, sir. And this is from personal experience. I've encountered a situation like this a couple of times in my practice, and what I do is I selectively engage the LED with the guide catheter. I know they tell us to try and avoid doing that for risk of dissection, but you know what? I'd rather take that risk. I'm stenting the LED anyways than having thrombus embolize down the circumflex. So that's one possible strategy you can implement for prox LED thrombotic lesions. And then the other thing that I found helpful is to keep the negative suction on the catheter all the way until you extract the device out of the guide catheter system. I've had a situation where my assistant inadvertently turned off the negative suction, and you end up with a thrombus going down the wrong way.
Thank you very much. Dr. Habib Gamra, would like to thank you very much for the very nice, elegant presentation and answering the questions and sharing your experience with us. And we invite you to stay with us for the rest of the day, because we have this meeting is broadcasting virtually, and we appreciate if you can attend this virtually. Thank you very much, and looking forward to be with us physically in the future meeting. Thank you.
Thank you very much.
Thank you. Now I would like to invite Dr. Ahmed Qasim from his consultant interventional cardiologist in King Abdulaziz University Hospital in Jeddah, Saudi Arabia, who will give us a talk on the challenge of heavy thrombus burden in STEMI case. Dr. Ahmed.
Screen, please. Bismillah ar-Rahman ar-Rahim. Thank you, Mr. Chairman. It's my pleasure to share this presentation. The challenge of heavy thrombus burden in STEMI. Of course, all of us know that in more than 90% of cases of STEMI, the presentation is total occlusion actually in the first 4 hours and declines till reaching 65% in the first 24 hours. And it is clear now by the data that primary BCI is the gold standard treatment for STEMI. And the recommendation, international, either European or American, it is a class 1 for primary BCI. But the big challenge in primary BCI is the huge thrombus burden. All of us know the TEMI thrombus burden classification and its grading from grade 1 up to 5. 5 is total occlusion. And Mehta proposed a thrombus-guided interventional strategy based on this TEMI thrombus burden classification. He proposed that grade 1, we can go for direct stenting. Grade 2 and 3, we can using aspiration thrombectomy. And grade 4, we can use angiojet. But the question, are these interventional strategies enough? I think not enough. Of course, the data about the manual aspiration, mechanical thrombectomy, and distal protection showed clearly failed to reduce infarction size or improve clinical outcomes in appropriately powered RCT. But the challenge when we're facing STEMI case is the total occlusion, what we call grade 5 thrombus burden. And of course, we need to make stratification. Grade 5, it is just only meaning TEMI zero flow, not high burden of thrombus. So we need to make restratification of this grade 5 by passing wire or small balloon 1.5, uninflated or inflated. Then we can restratify again the burden of the thrombus. And this angiographic features of Yeb's criteria for prediction of high burden of thrombus: large infarct-related artery, more than 4 millimeters, and incomplete obstruction with angiographic thrombus and cut-off pattern, accumulated or floating thrombus proximal to occlusion, and persistent diastasis distal to the occlusion. 2 or more of these criteria are prediction of very high thrombus burden. And it is clear from the data that also high burden of thrombus, it is carry a very high risk of morbidities and mortality, and high rate of instant thrombosis. Not only that, but also it carry a very high mortality effect, especially in the intraprocedural, including neuroflow phenomena, malignant arrhythmia, VTAC, VF, hypotension, intractable, congestive heart failure, cardiogenic shock, even cardiac arrest. And short and long-term effect, including post-PCI massive microinfarcts, early in hospital mortality, increased infarction size, progressive LV remodeling with poor function, and propagation of thrombosis and cardiac rupture and late mortality. And this is a very important data about the factors favor large thrombus burden. Actually, as Dr. Habib mentioned, ectasia is one of these factors, and aneurysm, old Savannah's vein graft, but most importantly, late presentation. Late presentation give high thrombus burden. Not only that, but also it can causing damage of the myocardium and predispose for the poor outcome after that. In our region, in Gulf area, according to the data published, Dr. Al-Habib in his study, it is very late presentation, most of our patients, in comparison to the data published from USA and from Europe. And the most important actually is the total ischemic time. Total ischemic time involves patient delay and system delay. Of course, all the international guidelines pay attention to system delay, to optimize the system delay to 90 minutes or 30 minutes, door to needle, door to balloon. But what about patient delay? Patient delay is the most important factor because patients can present it after 24 hours after already loss of the myocardium. And this is what we call wave front phenomena, which is actually the starting of the necrosis and damage of the myocardium from endocardium and progressed gradually until reaching complete transmural death of the myocardium in the first 4 hours. So early reperfusion is the solution for prevention and reduction burden of the thrombus and the outcomes and mortalities. This example for patient who went to the polyclinic in our center, in our city, after 1 hour, he loaded in this polyclinic after ECG done, showed ST segment elevation is anterior leads, loaded with ticagrelor and aspirin, and referred to our center just only within 30 minutes. And patient arrived and ECG done showed complete resolution of ST segment elevation after only 30 minutes from loading of the antiplatelets. So this is the point. Early presentation can make effective the solution of the thrombus and reduction of the burden of the thrombus. And this is what we done for this patient. Primary PCI, it showed the recanalization with a stent deployment for this patient. And this is very important data about the time delay, infarction size, and microvascular obstruction, showing the correlation between total ischemic time and the infarction size. As the time is very short, the less the infarction size. As the time is very short, there is less destruction of microvasculature. As the time is very short, there is improvement of the LV ejection fraction. This actually another patient, late presentation after 12 hours. Sorry. This patient actually presented late to us. After late presentation is divided into early late presentation and late presentation. Early late presentation from 12 hours up to 48 hours, and the late presentation after 48 hours. So this is late presentation after 12 hours. I passed wire for this patient, this dispersion of the thrombus distally and no flow for this patient. So I decided to make aspiration by export catheter. Of course, all of us know the data about this manual aspiration, and the no benefits from manual routine aspiration according to the total trial in reduction of risk of cardiovascular death, recurrent MI, cardiogenic shock, class 4 heart failure, but also common raising of stroke at 30 days. But despite this, I decided to use manual aspiration. As a question, which cases we should use manual aspiration despite this not recommendation? Of course, one of this recommendation to use manual aspiration is large thrombus burden, grade 3 or grade 4. Large area at risk, like patient as a proximal LAD or proximal RCA, or pre-existing severe LV systolic dysfunction. And this is a very important point actually, because pre-existing LV systolic dysfunction predispose for poor outcomes in table for this patient. So I make aspiration, and this is what comes out, a huge burden of thrombus. I make 5 runs, and this red thrombus color actually, and the data mentions that red thrombus is correlated with high burden of thrombus. So when you see red thrombus, you expect there is underlying a huge burden of thrombus actually according to the data published. And not only that, but also red thrombus is correlated according to the data published by Kedros et al. With the high miss rate, high death rate, high MI, high revascularization, and CVA. So after I make aspiration, I get TME2 flow. So I decide to inject intracoronary medication, nitroprusside, adenosine, and nitroglycerin. Usually I'm injecting the medication not through the guide catheter. I abandoned this maneuver since 8 years, more than 8 years. I inject selective distally through export cast itself. I make aspiration with. It is more effective than injection through guide catheter. So I make injections of medication, and I decided to make direct stenting for this lesion. But the question, is direct stenting really can prevent distal embolization? Also, I doubt, and I don't agree, because we have now data about this issue. So I decided to deploy stent directly, 2 stent, 1 proximal and 1 distal, and this is what happened immediately after I deploy the stent. There is bradycardia, hypotension, heart block, and slow flow. Within a few seconds, patient having polymorphic VT, DC shock given, again polymorphic VT, DC shock given, and antiarrhythmic medication given to this patient, and he stabilized after that. Of course, with deployment of the stent in a huge thrombus burden, there is still residual burden of thrombus. The data showing us, I will show now, that still there is a huge burden of thrombus residually despite we making manual aspiration. So there is massive distal embolization of this thrombus, can causing acute massive ischemia, and of course arrhythmia, contractile dysfunction, shock, and complication. And this is actually very important data comparing the manual aspiration with angiojet OCT study, showing surprisingly that 60% of cases of manual aspiration still there is a huge thrombus burden despite aggressive manual aspiration. Also in the angiojet, 37% residual thrombus burden despite angiojet aspiration. And this study actually showing that both techniques even don't allow for complete removal of the thrombus from this huge burden of thrombus cases. And this OCT images after manual aspiration, showing clearly there is a huge burden of thrombus after the manual aspiration in comparison to angiojet. So we can predict after manual aspiration, with deployment of the stent directly even, you can have a complication due to this burden of thrombus. So deployment of the stent in burden of thrombus high, of course, can causing prolapsing of the thrombus and distal embolization. And also, even if we're jailing the thrombus by the stent, This jailed thrombus having a very high risk of late instant thrombosis by acquired malabsorption later on due to the solution of this thrombus. Those two images from my own cases. So this is another important data from OCT study showing also the effect of residual thrombus. This is the OCT study and showing that patient with great residual thrombus burden had worse microvascular outcomes. So after stabilization of this patient, I decide to tackle this distal PDA. Actually, this is what we call embolic no reflow phenomena. And I'm using for this of course, the predictors of this embolic neuroflow phenomena, including the longer stent, low ejection fraction, age more than 60, female gender, but most importantly, RCA as a culprit artery and big size more than 3.5. So I decided to make fragmentation of this embolic large thrombus distally in PDA, and then inject also selectively distally through extraoral catheter medication, including nitroprusside, trufepan, adenosine, and this after I fix this embolic distal neuroflow. It is actually big artery. Patient stable, transferred to ICU, and went home after 3 days. Another important issue about using a big caliber catheter like the extension catheter or guidezilla or guideliner catheter in the issue of big thrombus. This anterior STEMI patient presented late also after 18 hours. This spider view showing a huge thrombus burden with a tight lesion proximally in LAD. So I decided to make only just a small balloon dilatation for the lesion itself, away from the thrombus. Very short balloon, 8 millimeters only. And this after we make dilatation, then I decided to make intracoronary OCT for this patient to assess the underlying mechanism and vasogenesis of the plaque. Of course, it showed the very huge red thrombus and this huge underlying lipid-rich plaque in this lesion. Of course, OCT is very important in the acute coronary syndrome because in fibrous lesion, we can use safely balloon dilatation, while in fibrofatty lesion, we can go for direct stenting to avoid the distal embolization. And in case of calcification, it is very important to use NSC balloon and scoring balloon, atherectomy, and IVL in such cases. Our patient actually showing lipid-rich plaque. So I make aspiration with the guide liner, and this is a huge thrombus comes out at the tip of the guide liner here, red thrombus. And this after make aspiration and stent deployment. And this is the final results, TMS flow without any complication. So the impact of huge thrombus burden is mainly in the microvasculature, either macro embolization or micro embolization. And this tissue neuroflow phenomena or myocardial neuroflow, it can assist by myocardial pressure reading, is the segment resolution, myocardial contrast echocardiography, and CMR. But still, in 35% of patients, despite the presence of TMS flow, still there is underlying tissue neuroflow in such cases. And the issue of microvasculature is very important. We're having 3 types of the micro vessel, including type 2, which is transmural. And of course, we know from this data that the process of wavefront phenomena starting from the subendocardium. And this also the type 4 microvascular dysfunction due to iatrogenic intervention with distal embolization. So prevention is better than treatment in the issue of a huge thrombus burden. We should pay attention to protect the microvasculature. Sorry, I have diabetes. But another important issue is the microvascular protection strategies. Of course, one on top of these strategies is the defer stent strategy. And also these 2 cases, actually, I just bring before and after a huge thrombus burden. First one presented with a huge thrombus burden, inferior presentation, this patient, and a huge burden of thrombus actually. So I decided to differ stent for these cases. There no way for this a huge burden of thrombus to deal with aspiration catheter. So I decided to differ the case and give oral anticoagulation. First patient was coming for Umrah and he will leave after 1 month. So I decided to repeat angiography after 3 weeks only, and this after 3 weeks, showing a significant effect of the warfarin only after 3 weeks, and the second patient after 3 months actually. Second most important line for this huge thrombus burden, a pre-hospital antiplatelet. And like the case I mentioned, it is very important to make loading, especially with ticagrelor or prasugrel, not with Plavix. Plavix acting after 2 to 6 hours, so it has no effect at all until patient arrive to the cath lab room. So I think pre-hospital antiplatelets is very important. Pre-hospital also thrombolysis, when we expect that patient will delay for transfer to PCI cable center, we should use pharmacoinvasive strategy and also using of cangrelor as intravenous line for patient intubated or cannot swallow the medication, and using a flow dose distal intracoronary thrombolysis selective injection. Also, it is another important issue for management burden of thrombus, especially in patient in not clinically stable and still there is burden of thrombus high despite we make many time aspiration. Also, MGuard stent and the stents, I think there is limited data about this MGuard stent, especially MGuard2 study showing a lot of slippage of the stent from this type of stent, and also excimer laser, especially after the limited study that done after that proves the effect of laser therapy in STEMI cases. So, take-home message, still no gold standard therapy to deal with thrombus burden in STEMI. It is case-by-case strategy. Large thrombus burden carries a high risk of embolic neuroflow and tissue neuroflow phenomena. Large thrombus burden had worse clinical outcomes with high MACE rate and acute in cath lab or short and long-term outcomes. Red thrombus, especially associated with high thrombus burden and high rate of embolic neuroflow phenomena, and aggressive management of large thrombus burden, including combination of pharmacological and mechanical therapy, is the key in resolving especially embolic neuroflow and tissue neuroflow and improving the clinical outcomes, especially the pharmacological strategy and different stent strategy and manual therapy. Thank you.
Thank you very much, Dr. Ahmed Qasim, for a very nice, elegant presentation showing cases together with evidence-based medicine supporting your management strategy. So if I give the opportunity to the panelists, if they have any comment, questions before I leave to our delegates and participants to ask any questions. Dr. Ali, tfadal.
Thank you. Very nice. A lot of useful information. I just have a question regarding the guide extension catheter use in terms of extracting the thrombus. I've tried this a couple of times, but I think the issue with the guide extension is that you can't put negative suction. You know, the aspiration thrombectomy catheters, there's an end to the catheter where you put negative suction, while the guideline there's no end, it's just you know how it is. So you use the side port in your whatever setup you have, use the side port to suck. So I'm just wondering, how do you put negative suction in the guide extension?
Yeah, from side port of the 3 ways, and I make good engagement of the guide caster itself. It is very important to make well-aligned, engaged guide caster. Then from the side way of the 3 ways, you can connect the syringe and make aspiration after that.
Okay, so you use the aspiration thrombectomy syringe to
Yeah.
You can use it?
Yes.
Okay.
Any other question from panelists? I will ask Dr. Ahmed, you show us the last case of ectatic with a very heavy burden thrombus. So wonder, what's your comment on the laser? Because this is ectatic, a huge thrombus from proximal up until distal. So there are data in the literatures, especially the Chinese, showing that the laser is really effective in dissolving and improving the flow.
Yes,
So
I think.
when do you consider it, and have you used it as in the case of heavy burden thrombus?
Yeah, I think these two cases are a clear example for the laser use after the Carnell study, which showing very effective laser therapy in huge thrombus burden and the dilution of the thrombus, fragmentation of the fibrin, and even evaporation of the thrombus itself. With and also this study, Carnell study, showing less dissection, less perforation, just only 2% of cases. So this is the indication for laser therapy, but it is limited study, not a huge randomized study.
Have you used it?
No, we don't have laser in our center actually.
Okay.
But I want to just add that I have my own proposal for management of huge thrombus burden, especially in different stent strategy. When there is early presentation of the patient below 12 hours, and there is still a huge thrombus burden distally despite failure of many times aspiration, I think this indication for different stent strategy for 2 or 3 days or 4 days even with antiplatelets, 2B3 inhibitors and potent antiplatelets. But if this patient presented late presentation, more than 12 hours or 24 hours, with a huge thrombus burden like this patient, and I think better to differ for weeks or months, an oral anticoagulation in addition to potent antiplatelets as well.
Doctor, تفضل. You have a question? Sure. تفضل.
Ahmed, thank you very much for this excellent presentation as usual and excellent elaboration. I just have not one comment, just want to ask you what's your experience about using filter wire or spider wire in high thrombus burden. I know it's classically used for savannous vein grafts, but I have recently seen online and few cases that has been recommended that has shown good results after usage of spider wires or distal emboliization protection. So any experience with that or something you know about the literature? I have never used that, I never tried it, but I've seen it. So I just want if you have any comments from you or the panel about this.
Yeah, I showed one slide only about the distal protection devices and filter wires. I think there is no data supporting this except in the savannous vein graft. It is by American guidelines. It is only class 1 indication for savannous vein grafts, but not for routine for, yeah. But I don't have experience in this in our center. Yeah. We don't have in our center, unfortunately.
Okay, thank you. Doctor, تفضل.
Thank you so much, Dr. Ahmed. Excellent presentation. I just have a comment. You know, we have to put in mind, we always remember that the first aim in treating acute STEMI is restoration of flow. And this is, if we have a big thrombus burden, I don't, you know, from my experience, I try to avoid putting a stent unless I can, you know, clear the field or prepare the lesion before I put my stent. It's not a good idea to put a stent when there is a big clot burden. So one has to prepare the lesion very well. We have also to remember that thrombus is not something to remove mechanically because it's very sticky, it is very difficult to remove, and that's why maybe the manual aspiration is not successful in most of the cases. So giving medication is extremely important here. Giving, you know, intracoronary GB2 inhibitors or, you know, high doses of antithrombotic. If you restore flow, TME3 flow, maybe you can postpone putting the stent, or, you know, by giving the medication overnight and then prepare the lesion properly before you put a stent. Also, we need to remember that there are other medications that can help in no flow phenomena like intracoronary adenosine, nitroglycerin, and epinephrine, which works very well for me. So I think we have to put all this in mind when we deal with big burden clot, which is a very challenging situation. Thank you so much.
Yeah, thank you for your comments. I agree totally with you that number one, and most importantly, to resume the flow. This is the most important. Number two, we should stratify the burden of the thrombus. If the burden of thrombus is still high after we make many time aspiration, we can call it failed aspiration. So after failed aspiration, we should choose between two strategies. If the patient is stable clinically, so we can differ this patient. If patient unstable clinically, still symptomatic, chest pain, and so on, we should treat in table this patient, give intracoronary medication, even we can give intracoronary thrombolysis. And this one one of the indication of intracoronary thrombolysis. Patient, after failure of the aspiration many times, still patient is clinically unstable. So we should give thrombolysis in this case. One more important point, we should use in these cases a transradial approach, because a transradial approach helping us to go aggressively with antiplatelets and don't fear from the bleeding risk from femoral access.
Good point. Dr. Albert, تفضل.
Thank you very much. It's a very elegant presentation. I think we all pay attention to the lesion, thrombus, and so on, but as you've demonstrated, the microvascular bed is essential in the category of acute coronary syndrome, and we need to pay more attention to that. Now, there are trials, as you know, we did one in Leicester using cardiac MRI about microvascular, and the impact on the long-term outcome is really phenomenal. So the less insult on the microvascular bed, the better the outcome for the patient in the long term.
Yes.
Hence, I agree with Dr. Fikri, perhaps during the procedure, I think we need to take our time. And I disagree with Dr. Habib that, putting stent in that meta-analysis has proved to be beneficial for those patients. I think the data from those trials that have been used in this one, it's an old-fashioned data. B, I think being fast during the procedure, I think is the wrong conception. As mentioned, Dr. Fikri, take your time, I think.
Yes.
Use the vascular image, respect the microvascular disease. And do you think, one question for yourself, do you think the future research or trials in acute myocardial infarction should focus more on any method to respect the microvascular disease and try to protect it, i.e. more data about randomized mechanical, and we know there are some trials ongoing now, but about using mechanical thrombectomy, using distal, as you've said, nitroprusside, all the medication that can improve the microvascular disease, and more about the antithrombic treatments. More specifically, I'm not convinced in injecting locally. I think the data so far is contradictory. Some of it have shown that you increase the myocardial bleeds if you inject directly rectal place inside the lesion. So I think there is more different direction now in terms of the studies, the future generation of studies, looking at these three factors mainly in acute myocardial infarction. Do you agree on this?
Yes, as regard to the initial points about take your time, yes, totally agree, take your time. I think the case Dr. Habib showed, which is die-unstable due to stenting of this patient with a huge thrombus burden. I think in huge thrombus burden, take your time, differ the case. Don't rush for deployment of stent with underlying huge thrombus burden. You will destroy the microvasculature. Microvasculature is very crucial in the outcome of patient in stable and in short and long term. So take your time and give this thrombus time to dissolve by antiplatelets, by antiplatelets and anticoagulation as well. This is what we call marination. Marination means you give the patient anticoagulation and antiplatelets and 2B3 inhibitors over 2-3 days. This is the literature definition of marination. And another important point, also, as you mentioned, there is, yes, a lot of researchers now about the prevention now. What I read the literature that we should, this I'm raising very important point, because our patients, according to the literature, coming to us very late. He went to polyclinic before to refer to us, then come after 18 hours, after 24 hours, very late. This is after damage and after completing of the what I call the wall front phenomena of necrosis, which is actually damage of the microvasculature. So you expect even without high thrombus burden, poor outcomes in this patient with late presentation. And another points about the future research about the, yes, there is now data about advanced technology. One of this raising issue about is the wide pore aspiration catheter to modify the export case and using the, for example, I showed now the extension catheter. So we search for wide pore catheter. We can using advanced technology for this point.
Thank you very much. I would like to conclude the session of heavy burden thrombus. So great thanks to Dr. Habib Gamra from Tunisia for the nice scientific presentation and tips and tricks on the management. I'd like to thank my panelists, Dr. Fawaz Al-Mtayri and Dr. Ali Salimi and Hatem Al-Lawati. And finally, thank you, Dr. Ahmed Qasim, as a panelist and a presenter for the very nice, elegant presentation. Thank you very much. And now I will announcement before I move to invite Dr. Khalid Bithani to chair the session.